Okay, think we can start. So good morning, everyone, and welcome to today's session of the Teletrauma Grand Rounds. So today we have Dr. Badami, who's a surgery, critical care and trauma fellow at Ryder Trauma Center at Jackson Memorial Hospital, presenting a case titled "When the Bullet Messes with the Pancreas." So over to you to start the presentation.
Thanks, Maya. All right, good morning, everyone. All right, so like the title said, we'll be presenting the bullet that doesn't read the textbook and messes with the pancreas. And in this presentation, we'll be discussing a few important topics. Firstly, the management of penetrating pancreatic-duodenal injuries, operative techniques and consideration. And lastly, the management of post-operative complications. So this patient is an 18-year-old gentleman who presented at our trauma center after sustaining a gunshot wound to the mid-abdomen. Per the EMS, patient was a GCS of 14, kind of intermittently confused. They said they were able to palpate the bullet at the back. They saw one aperture on the anterior abdomen. He was able to move all the extremities, and during the course of the transport, he became less and less responsive and diaphoretic. So on our initial survey, patient was protecting his airway. He was kind of talking, mumbling initially when we saw him. He had bilateral breath sounds. His initial vitals were 90/45, heart rate of 110. Bilateral reactive pupil, GCS of kind of 14. Verbal, you had to arouse him, and he was answering questions. On exposure, we could see an obvious aperture in the mid-central abdomen, kind of periumbilical region on the right side. On a quick secondary survey examination, pretty much the same thing. No other apertures throughout. We log rolled him, turned him. We did see the bullet, could palpate it under the skin on the left side, kind of lateral to the spine on the left and the back. And this one single aperture in the periumbilical region, as you can see in the schematic. So what will you do next?
Thank you, Dr. Badami. Dr. Armchak, would you like to make your comments first?
Yes, so pretty straightforward case. He's a penetrating injury to the abdomen, and he is tachycardic and hypotensive, not profoundly hypotensive, but in shock. And so he needs 2 large bore IVs, a sample to the lab, setting up some blood. And while that's going on, I would do an EFAST exam. You can do a chest x-ray, but EFAST, I think, is faster. And regardless of what you see in the abdomen, he needs a laparotomy, but I would still do it anyway. I think it's just part of the physical exam. And then I would transfuse him with 2 units of O negative or O positive or negative packed cells as soon as you can get them, unless you can get the bank blood faster, and see how he responds. And I wouldn't give him more than about 1 liter of crystalloid. And if he proves to be a responder, then and he remains stable, you can do a CT if you like, or just take him to the operating room. If he's a transient responder or non-responder, he needs to go urgently to the operating room. If he's a non-responder, it needs a setup for the master transfusion protocol. So I would limit the amount of testing done, but I would do it in that sequence.
Thank you, Dr. Armchak. Dr. Hodgman, do you have any comments?
I'm sorry, Maya, one more thing before Dr. Hodgman comments. I think the other important key pertaining finding was also, of course, he was like peritoneal on examination.
So the thing in the back is the bullet palpable, not another opening.
Yes, sir.
Correct. So this I will limit the amount of studies I do, and I will take this. I will overdo the ABCs and take this patient to the OR. I wouldn't do any other study.
Your email?
I'm sorry, can you hear me?
Yes, sir.
Yeah, so, and I will go to the OR. I will limit the resuscitation by the time I go to the OR that has better outcomes. So I will allow for some permissive hypotension With systolic around 90. But that's it. Really not too much. This is a straightforward case, as Dr. Untrak said.
Thank you, Dr. Hodgman. Dr. Managozo, would you like to make any comments?
Hi, everyone. Good morning. I agree with Dr. Untrak and Dr. Hoffman. I think that this patient needs OR as fast as possible. And I would also try to limit a little bit the resuscitation to give him the benefit of a hypotensive, of a permissive hypertension.
Thank you, Dr. Managozo. Dr. Post, would you like to make any comments today?
Yes, good morning to everybody. Yeah, I agree with everything what has been said. I mean, every minute counts here. You should go immediately to the operating room. I would activate MTP as well. That allows us to get blood immediately. But you should spend maximum 2-3 minutes in the trauma bay, not more. There's no rule for any imaging here. No rule for CT scan. Just proceed directly to the operating room. So we would just, cut off all the closing, take a type and cross sample, usually a groin stick, and rush them to the OR. Everything else is done in the OR, intubation, everything else done in the OR. So maximum 2-3 minutes, and we have shown the data that with every minute you delay transfer to the operating room, the mortality goes up.
Thank you, Dr. Post. Back to you, Dr. Badami. Continue.
Thank you. So I, again, we agreed with the faculty that mentioned that, he needs to go right away to the OR, and that's exactly what we did. He was taken directly to the operating room after 2 large bore IVs were established. We just sent a blood for type and cross, and next minute he was in the OR. In the OR, we started with the exploratory laparotomy. A massive hemoperitoneum was encountered, around 2 liters of blood that was encountered, evacuated, and then we definitely right away noticed a zone 1 hematoma. Packed the abdomen, and at this point of time discussed with anesthesia, gave him some time to catch up from anesthesia standpoint. So what's next?
Thank you, Dr. Badami. Dr. Managozo, would you like to make your comments first?
Thank you. So yeah, I think that the main idea is first you get control of the bleeding, and since this is a zone 1 injury, you have to be concerned of the major vessels, and of course the parenchymal lesions, they can also bleed, but the problem here I think would be mainly considering the great vessels. I think that the idea of doing an initial tamponade to make sure that the anesthesia guys can catch up is a very nice idea, and I think that the surgeon needs to be aware that sometimes the compression is not so effective. So you have to be sure that you're compressing in the right position to make sure that you're going to have these as fast as you can. Also, I think it's considering the possibility of the lesions, it's very important to have proximal and distal access to every major vessel. You need sometimes to control the aorta or the vena cava to make sure you are going to have the best control possible when you're going to address the injury. And I think that in this case, considering the massive hemoperitoneum, maybe one idea here is to get some equipment to do an outward transfusion as well, because you can do the transfusion from the blood from the patient. So sometimes it's a nice idea to do this as well.
Dr. Managozo, Dr. Hodgman, would you like to make any comments?
Yes. Well, I am going to say something very will be a heresy, and I can say this because Dr. Rodriguez is not here. But bullets don't, contrary to popular beliefs, bullets do not bounce inside. Bullets tend to follow more or less a linear trajectory, or sometimes a curved trajectory, because the bullet spins. So based on the entrance and exit, the IVC is unlikely to be injured. So if it's any injury, I would think it's the aorta or any other vessel there, but the IVC is not. So based on that, my next thing will be to do a Mattox maneuver to get proximal and distal control of the aorta. So I will start by taking down the wide line of the colon, going lateral to the spleen, and flip over everything towards the midline. So that I would do that to get the aorta, whatever, see what is bleeding and go that way. Thank you.
Thank you, Dr. Hodgman. Dr. Quist, would you like to make any comments?
Yeah, for sure. You mentioned that you said you pack the abdomen. You know, you have to be very careful because packing is not going to work for like a zone 1 hematoma or something with an aortic injury, right? Packing works great for liver injury and you do peripartic packing. So I think you probably meant to say you use laparotomy sponges to evacuate blood. You can see, but packing really doesn't work for those kind of arterial active bleedings, right? So I agree with Dr. Hodge, and you go and do a Maddox maneuver to get to the aorta, or if there's a massive hematoma and you may not get there fast enough, you may consider to do aortic inflow occlusion at the subdiaphragmatic area and put a clamp there at the aorta. Others people have put a rebore in. The issue with that is if you have an aortic injury, you may not be able to get across it also. Most of the time you do. So, rebore is an option if you have an aortic injury, but you're already in the abdomen, so you can just put a supersedure clamp at the aorta and then do a Maddox maneuver.
Thank you, Dr. Quist. Dr. Antrag, would you like to make any comments?
Yes, I agree with Dr. Hodgman about the trajectory. I think that's likely what happened here, and also about Dr. Pust about control. I'd just like to ask. So you get into the abdomen, you find the hematoma. What's his status? His blood pressure at the time? Is he putting out urine? What? And does he have distal pulses in the groins?
Yes. So at this point in time, his blood pressure, he has been as soon as we, were wheeling him to the OR, we activated the MTP. So he started getting blood. His systolics are between 90 and 100. Heart rate pretty much the same, around 100. Pretty much he stayed where he was during this entire course, and he had pulses.
And he's making urine. Yeah, about the rebow, it's not really caught on everywhere, or even in a lot of places, and some of the Army surgeons here just think that it's going to fall off the radar eventually. But in this case, to have to get control, depending on the habits of the patient, while you're letting the anesthesiologist catch up, I think it might be a lot faster to get access to the right femoral artery and then just have the reboa there. And if you get into bleeding, inflate it, put it into zone 1. And I think that for someone who's profoundly hypotensive, you have to get control of the diaphragmatic hiatus, put the aortic masher there, that big stainless steel instrument, just to hold it down. But it might be more elegant if you have access to it, and he has pulses, and you're waiting a few minutes anyway before you're going to start to dissect. That might be a good way to go. So I agree with Dr. Proust on that.
Thank you, Dr. Antrag. Back to you, Dr. Badami, to continue.
Thank you. So the next thing we did, of course, once anesthesia was a little bit caught up, blood pressure was holding, we did remove the packing, saw a hole in the gastrocolic ligament, entered the lesser sac, evacuated some more blood, no obvious injury to the stomach at that point in time. Because of the trajectory kind of right on the right side of the umbilicus, periumbilical region, we ended up doing a calabrash, immobilizing the right side, complete medial visceral rotation, along with a coker. Saw a destructive injury to the third portion of the duodenum. Approximately 90% of the circumference. We saw like 2 kind of anterior and kind of medial injuries, along with a large laceration from the pancreas that was bleeding. So with this information, with these injuries, the next step.
Thank you, Dr. Badami. Dr. Hodgman, would you like to make your comments first?
After I was completely wrong by suggesting a Matos maneuver, you're asking me to go first. Okay. Okay, so there you have to essentially identify where the bleeding is coming from and go that way. Anything can be injured in that area. If the bullet went through where you are marking there, both the IVC and the aorta can be injury. You might have bleeding from the branches of the portal vein. So you did a Coker maneuver. I don't know, try to find the bleedings and go from there. Try to identify the injury better. It's injury to the third portion of the duodenum. If it's so extensive, probably you cannot repair this. So I wouldn't try to repair anything at this time. I would just control the spillage and get out. I doubt very much that I will proceed with Whipple. So I would just control the spillage, control the bleeding, control the spillage, put drains and get out and reconstruct it at a different time. Thank you.
Thank you, Dr. Hodgman. Dr. Meneguzzi, would you like to make any comments?
Yeah, it's difficult to. I think it's a very particular intraoperative assessment and decision, but it's what I would be concerned here is where is the bleeding come from, as just as Dr. Hochman said. So I think that if the bleeding is coming from the duodenum or the pancreas, and there are no great vessels injured, I think you can get a control more easily on that. But I think that the problem is that how can you get a nice exposure of the great vessels in order to make sure you're not having any injuries there? So I would be a little more concerned about having the vena cava injury or the mesenteric vessels injury. So I think in such sense, if you are concerned about that, I would and you're going to see a lot of blood coming from there. So if that's what's going on and you are really concerned, I would probably prepare for a Whipple surgical procedure. But if you only have the duodenum injury and the pancreatic, sometimes you can do a compression or some sutures in the first procedure. I think I'm considering here a damage control approach. So I don't know exactly what was in the surgical procedure, but I think that I would really consider doing a Whipple procedure, only the resection, and leave the reconstruction for a second approach.
Thank you, Dr. Meneguzzi. Dr. Antra, would you like to make any comments?
Yes, so the decision point here is whether to do damage control, proceed with definitive a definitive operation, or something in between, and that has to be based on you being there and what the situation is. It sounds like he's stable, producing urine, he's normothermic, and he doesn't have a rising lactate level. So assuming he's stable and he's 18 years old, you might want to proceed, but I would be loath to jump immediately to a Whipple procedure because it might not be necessary. That injury in the third portion of duodenum, the Cattell maneuver, is ideal for exposing and resecting the third portion of the duodenum. It's a beautiful exposure for that. And as a first step, assuming that everything was fine, it's reasonable to go ahead with a definitive operation. I would consider whether you can, first of all, be sure you know where the bleeding is coming from, like Dr. Meneguzzi said, that there's no vena cava injury. And then before proceeding, you could also then do what you need to rule out an aortic injury. And in this case, I think you might have to do both the Cattell and also the Maddox maneuver, but you need to be sure you know exactly what you're dealing with before proceeding with anything other than damage control. Assuming that there's nothing else bleeding, but the vessels around the pancreas, you can start to, you have part of the dissection done, you did the Coker maneuver, you might see how easy it would be to resect the injured portion of the duodenum, and then in the process, what is left of the pancreas. If the main ducts are not injured, I wouldn't proceed with a Whipple procedure at this point. Either just resect the third portion, leave both ends stapled or sutured, and put some sutures in the bleeding part of the pancreas, put some drains and get out. If you wanted to, you can possibly leave a feeding tube distally, but I probably wouldn't do that. I plan to come back in a day or two and finish up. And so I would consider doing that. I don't think that I would, without being there, without seeing the situation, I don't think that I would proceed with anything more aggressive at that time. The other option is to, like the other said, put packs and drains and be sure that there's no more bleeding, get out and think about it and come back in a day or two and finish up.
Thank you, Dr. Unshag. Dr. Bush, would you like to make any comments?
Yeah, I agree 100%. Just a disclosure, I don't know bleeding from it, and you haven't told us yet, but I think it's important to figure out what he's bleeding from, right? You just don't want to blindly through sutures and you want to see, okay, is this a cava injury? Is this bleeding from the renal artery or vein on the right side? Is there an aortic injury, as already mentioned, or is he bleeding from the gastroduodenal? Because each of the injuries you may treat differently, right? The gastroduodenal, you can easily ligate, it's not a problem. Renal vessels, you could ligate if you sacrifice the kidney. If you decide, you may be able to shunt it in renal artery if it's an injury and come back later. But the principles are the same. First to control bleeding, and then you control spillage. As mentioned, it's definitely a damage control case. It's not the time to do reconstruction. It's not the time to be over aggressive and just go straight ahead to Whipple. You want to assess what really the injury is, because if the second portion of the duodenum and the ampulla of artery is intact and the head of the pancreas is intact, there's no need to do a Whipple, right? Then you can repair the duodenum and put drains and put a distal feeding access. And all that you're going to do in the second stage, in the second operation. But the first operation is just control of hemorrhage. But again, you want to identify what's bleeding, so you can cause further damage, right? If you have other vessel injuries, hepatic vein injury, you need to address it, you need to fix it. So it depends on what kind of vascular injury you have. So it's the same principles, proximal distal control, and then visualize, and then go ahead and either repair or ligate depending on what vessel you're dealing with.
Yeah, he's going to
Thank you,
comment.
Dr. Burst. Dr. Badami, back to you to continue.
Thank you. And I think those are all really valid and great points. And those were the points that we actually discussed intraoperatively as well. Sorry, one second. So initially we, because it wasn't like frankly exsanguinating bleeding, we packed the pancreas at that point in time. And as the faculties mentioned, we also examined the IVC aorta as well, which appeared intact. Didn't seem like the bleeding was coming from there. It seemed like the bleeding was coming from the pancreatic parenchyma, some vessels, collateral vessels around it. At this point in time, we also noted that the trajectory of the bullet was actually going on to the left side, left of the aorta, and decided to perform a Maddox maneuver and do a left medial visceral rotation to look at the left kidney and colon on that side. We saw the trajectory and the whole adjust into the spine on the left side and into the retroperitoneum, which was at that point in time packed. We ran the small bowel from the ligament of triads to the IC valve, along with the colon from the cecum to rectum, and no injuries were identified. We subsequently removed the pancreatic packing, mobilized the gastrocolic ligament, the gastrohepatic ligament, kind of put in a Penrose around the pylorus of the stomach and kind of lifted it up to get a better exposure of the pancreas and see exactly where the bleeding is coming from. It was from the pancreatic parenchyma, some vessels around it, which was suture ligated. And we just repaired the pancreas with the 3 Prolene sutures. As you can see, I have marked the area where we intraoperatively saw that the bleeding was coming from. So now once the bleeding was kind of under control, now it was just a slow ooze from the pancreatic parenchyma, we further directed our attention to the destructive injury of the third portion of the duodenum. As you can see, I've marked two lines on that third portion. So you can see a little bit medial and lateral. They both were kind of through and through injuries of the third portion of the duodenum. So what would you do next now?
Thank you, Dr. Badami. You'd like to make your comments first? Dr. Antl, would you like to make?
Yes. Certainly, yes. So as I mentioned earlier, third portion of duodenum is ideal to resect through this Cattell maneuver. The exposure is perfect. And that's what I would do here. I would just take down the ligament of Treitz and mobilize that piece of bowel. Probably staple across the fourth portion of the duodenum, include that with a resection, advance in the distal port, resection margin, fourth portion of the duodenum, first portion of the jejunum, advance it up, and then close the second portion, the proximal resection margin at the distal second portion. Probably you would need to do that with sutures and then do a side-to-side anastomosis along the greater curve of the duodenum. And that would get the anastomosis away from the area of the pancreatic injury, out of the area of primary injury. So that's what I would do there, and leave drains for the suture the pancreas, leave drains, and call it a day.
Thank you, Dr. Anjak. Dr. Hodgman, would you like to make any comments?
Without seeing the injury, it's difficult to say what to do. Probably this can, based on the description, probably this cannot be repaired, probably, but I am not sure. If I will attempt a repair, I would probably do a pyloric exclusion here and leave it all well drained. And if it cannot be repaired, it's a little bit more complicated. I probably will resect that area and do an anastomosis of the duodenum to the small bowel, most likely as it could be like a side to end to side, or like a Roux and Y, and go try to restore continuity that way. The problem is that you will have sutures very close to a potential pancreatic leak. So that will be not really a very good option. So, but sometimes you are forced to do things that are, you cannot find a better option. So in summary, I would probably resect that and do anastomosis a little bit higher, or just do a pyloric exclusion and sorry, not pyloric exclusion, do a gastrojejunostomy and leave it like that. Thank you. I don't think I will go for a Whipple, absolutely not. It's very tempting, but no.
Oh, thank you, Dr. Hodgman. Dr. Maragoso, would you like to make your comments?
Yeah, I was tempted as well. So as Dr. Hochman said before, now I'm wrong. I cannot make any further comments because I did something different. But I think that once you have controlled the bleeding from the pancreatic injury and you're not going to resect it, so you have this duodenal injury, and it's a big one, as Dr. Assami described. So I think I'm going to stick with the other colleagues, Dr. Hochman, Dr. Untracht. I think that the main decision here that I would be concerned of is really the problem of having the pancreatic injury close to the suture lines of the anastomosis, and also considering that this patient is not a candidate for damage control surgery, then I would perform the anastomosis in the same procedure as well. But I don't know how the patient was doing in this time of the surgery. How was the metabolic the metabolic complexity of the case. But I think that if the patient is maintaining a good micro hemodynamics, I think that probably the anastomosis is a good choice. I think that most duodenal injuries, you can do it probably just primary repair, but I think that this one is a really big one and probably destructive and with a lot of loss of tissue. So I think that resection and anastomosis would be better.
Thank you, Dr. Managosa. Dr. Post, would you like to make any comments?
Yes, I mean, most has been already said. Again, it really depends how large the injury is, right? If it's just a small caliber through and through injury, you probably can do primary repair. If it's more than 50% circumference of tissue loss or destruction of the duodenum, I agree with Dr. Untracht. I would staple and resect. I think it's important to visualize where the ampulla is. So if it's a large injury that you're going to have to resect, you should be able through the injury to look up into the duodenum and see where the ampulla is. So you're making sure you're not stapling across it, because obviously if you compromise that, then you're pushing the patient into a Whipple procedure potentially. And we, as we all agree on, we're really trying to avoid to do a Whipple here. It sounds like you're very distant to it, but you want to make sure that you establish that there's no pancreatic duct injury and that there's no involvement of the ampulla of artery. And if you did that, you're on the safe side. And then, as mentioned, if it's too small through and through holes, I would do a primary repair, put drains in, put feeding access in, plus minus pyloric exclusion. And if it's larger, I would do staple it off and then do the reconstruction at the second stage. So the principle of damage control remain. Even if I would repair the duodenum, if I had major blood loss and the patient is sick, I would come back the next day and look at it again and make sure everything looks fine and close the abdomen at that time.
Thank you, Dr. Post. Back to you, Dr. Badami, to continue.
Thank you. And I think, with whatever all the faculties mentioned, we probably discussed like every single point intraoperatively. It was really tempting to do the Whipple as well, because that was also a discussion that I had with the attending, because it was like right at the head. Primary repair versus resection, reanastomosis, all those were considerations intraoperatively. So what we did is we basically created this plane, dissected out the avulsed kind of head of the pancreas, the Uncinate process, created a space between the duodenum and the Uncinate process to just look at the medial aspect of that injury. We, at that point in time, we did attempt to repair the duodenal laceration with kind of two-layer repair with Proline and then Lambert's, both medial and lateral repair. Just because it was tempting, and we learned from our mistake, because after doing the repair, we didn't have a lumen at the end, because it was a pretty significant circumferential injury from the bullet, and the edges of that repair appeared ischemic as well. So we ended up right away deciding that we are going to resect that portion of the duodenum. Now the missing step. I think the missing step was covered by Dr. Pust, which was where is the ampulla in relationship to the injury, and in order to evaluate that, we basically performed a cholecystectomy, ended up transecting the cystic duct, and with a Fogarty went in through the cystic duct and into the duodenum, blew up the balloon and pulled back on the ampulla and could manually palpate the ampulla in the second portion of the duodenum. And this was the injury was distal to it. So knowing where the ampulla was, we dissected the duodenum around that and second and third portion, and we transected the duodenum distal to where we palpated the ampulla. The next step we did was what actually Dr. Untracht rightly alluded to. Freed up the ligament of triads, pulled back retrocolic, the fourth portion of the duodenum, and then transected the duodenum between the third and fourth portion of the GIA, and finally removed resected and removed the injured duodenum out of the body. And then subsequently got the fourth portion of the duodenum, since we had already released the ligament of triads, next to the second and third portion where we had a previous staple line. By this point in time, after doing the repair and then resecting, a patient was started becoming hypothermic, was kind of oozy. So we decided to call it a day, abort, take the patient to the ICU for resuscitation, and come back the following day. During this entire process, the patient received 4 units of whole blood, 2 units of packed blood cells, 1 unit of platelets, 1 unit of cryo, and urine output was 450 cc's. We were concerned about the spinal injury, even though patient was able to move the lower extremity, some any kind of occult spinal fractures just because of the trajectory, since it crossed the midline, crossed the spine. So patient did get a post-op CT scan, incidentally found to have left lower lobe PE, and the ballistic fragments in the back, the level of L3, but there was no fractures, and this is the CT scan. So any questions, any thoughts so far before the take back?
So right now I missed it for a second. Right now you basically stapled it off and you did damage control. So you're in discontinuity right now with a stapled off duodenum, right?
Yes, sir.
Okay. So as mentioned earlier, I mean, you have to plan now how you're going to reconstruct the patient on your take back, right? So as soon as, physiology is okay, meaning the acidosis resolved, coagulopathy is resolved, and the patient is hypothermic, normothermic, you take him back to the OR, and then you have to see how you're going to reconstruct him, how you're going to do the anastomosis. If you're very close to the ampulla, you won't have space to put a stapler and do a stapler anastomosis. I think in that case, you should opt for a hands-on anastomosis. Either bring up wound limb, as mentioned before, or just the proximal jejunum directly. Or if there's not, if it's mobile enough, you anastomose the fourth portion of the duodenum. So it depends. You don't want to have any tension, obviously, but those are our options. But you probably got to go hands-on here if you're close to the ampulla. You're going to have a very high risk or likelihood of leak of this anastomosis. As mentioned by Dr. Antwerp, you have the activated pancreas there and everything. So you have to plan for that, right? So you want to put large drains in, and you want to have distal feeding access. So I would put a feeding jejunostomy, and then plus minus the pyloric exclusion. Some people like to do it, some people don't do it. We kind of, in most cases, moved away, but if it's a major injury like that, I would consider it. I stopped doing gastrojejunostomies. I think it's an unnecessary anastomosis, which can also leak. You don't need it. You can just drain the stomach with an NG tube and then have distal feeding access via feeding jejunostomy. So that's what I would do.
Thank you, Dr. Post.
I think I agree with Dr. Post. I think he put it really well, the idea and all the alternatives to do that. I think it's I agree.
Thank you, Dr. Manapose. Dr. Hodgman, would you like to make any comments?
So this is the beauty of this conference. We find different solutions done in different places based on the local experience of the surgeons, and all get good results. Again, you have two options. Either you staple the duodenum distant to the papilla and do a gastrojejunostomy, or you do an anastomosis between the distal you resect the fourth portion of the duodenum, close it there, and you do a end-to-site anastomosis of the duodenum to the jejunum. And I agree with Dr. Proust, you don't have room here, this has to be a hands-on anastomosis. So those are the only options that we will do here. We probably wouldn't do a feeding jejunostomy. I know that in many countries, feeding jejunostomy and routine. We hardly ever do it here for many different reasons. So, but that we will do. This is, without seeing the injury, it's very difficult to say how we can reconstruct this. Thank you.
Thank you, Dr. Hodgman. Dr. Unchak, would you like to make any comments?
Yeah. So I agree with all the comments, and in this case, I probably wouldn't do a pyloric exclusion if it's not a primary duodenal repair, and if you do pyloric exclusion, I think normally you also have to put a duodenostomy tube. I don't know. Does anyone do pyloric exclusion without duodenostomy tube, so to decompress it? But I probably wouldn't do that. But I agree. In this case, because you might have to contend with the pancreatically, I would put the distal, the catheter feeding jejunostomy, and you can staple across the distal resection margin, the proximal resection margin. You probably need to hand sew, and then I would do, as I mentioned before, just a side-to-side anastomosis of anti-mesenteric border of the fourth portion of the duodenum to the end, and the first few inches of the jejunum to the greater curve of the second portion of the duodenal sweep, and then leave lots of drains. And I think that would probably be okay, depending on the degree of soilage and the degree of leak that you see at the time. If I can just ask, when you tried to repair the duodenal injury, were you not able to see the ampulla?
No, we were not able to see the ampulla. It was distal, so through the injury, we were not able to see it.
But through the wound, so it was too high to see, or
It was high. It was, I would say, a decent.
Yeah, but right. The issue is whether you needed to take out the gallbladder to do it, but it worked. And how long was the first operation?
It was like, I would say 2 hours approximately.
Okay, and the cholecystectomy was what, 10 minutes of that?
Yeah.
Okay, so I think that that's fine. But anyway, that's the way I would proceed. I think you're winning in this case. But
can I make a comment? Two things. I think Dr. Hodgman made a very important point, right? Any extra hole in the bowel, unnecessary hole in the bowel is a risk for a leak and problems, right? So for the feeding jejunostomy, if you don't want to put it, what we do sometimes, so if I think the likelihood of a leak is low because, let's say, it was just a stab on or not a very destructive injury, what I do is I just tack a loop of bowel, 30 centimeters distal from the ligament of triceps. I tack a loop of bowel against the abdominal wall on the left side, and we mark it with 4 clips. So you get like a target sign. So if you do need to get a feeding jejunostomy, it makes it much easier for the interventional radiology colleagues to look on a fluoroscopy where the 4 clips are. It's like target site.
That's not the practice.
And just put a needle through there and put a feeding jejunostomy in there when you need it, right? But you have tacked the bowel already through the abdominal wall and you know where to go, so it makes it much easier for them. If it's a very destructive injury like this one, where you have pancreatic injury, you repair the pancreas, there's likelihood of anastomosis. I would be more concerned and would probably proceed with the feeding jejunostomy. Regarding the gallbladder, you don't necessarily need to take the gallbladder out, especially not in the first case, right? When the patient is colopathic and stuff, you can just make a little opening in the gallbladder, put your balloon catheter through down to palpate the ampulla, and then just whip stitch it and take it out on the take back, right? So you don't have to take out the gallbladder right away in order to put the balloon down.
Thank you, Dr. West. Back to you, Dr. Badami.
Thank you. All right. So the patient, from physiological standpoint, did okay overnight. The coagulopathy was corrected, was normothermic. acidosis improved, and then subsequently was taken back the following morning, took down the vac dressing, and evaluated the proximal loop of the jejunum that had basically laid across on the side, and then basically did exactly what actually Dr. Antrak had alluded to, did a side-to-side hand-sewn anastomosis, left a bunch of JP drains around that side, and then also heard Dr. Pusta's comment and brought a loop of jejunum distal to the triads and basically tacked it to the abdominal wall in case we require future feeding access, and because of the concern of the leak from such injuries, and then close the fascia and the skin. At this point in time, when we opened up when we made the duodenotomy at the second portion, we were able to, of course, again, evaluate and see the ampulla again, make sure that, we don't compromise that in our repair. I think that's also a key important intraoperative point when you're doing such repairs. Now, post-operatively, on post-op day 2, patient was extubated. He was doing fine between 2 and 3. Over the course of the day, subsequently became diaphoretic, hypoxic, with worsening chest X-ray. He was the chest X-ray showed patterns of ARDS. The hypoxia was refractory to nitric oxide, paralysis. PF ratio was 49. He was being bagged intermittently for worsening compliance. And as you can see, the ABGs at the bottom, his O2 was 49, 66, 80, and this was on like 100% paralyzed. So he decompensated, unfortunately, right after extubation, within a few hours, pretty quickly. These are some chest X-rays. This is right after extubation on the left side, on the right-hand side of the screen. When the patient was hypoxic, he had gotten intubated. So at this point in time, now moving on to a little bit critical care section, what would be the next step in this patient?
Thank you, Dr. Badami. Dr. Managosa, would you like?
Yeah, I think that reintubation is a good idea. Of course, he's not responding to the treatments, so I think that you have to intubate and you have to consider all the relevant situations that might be at hand here. I think that this patient has had a lot of risk of having such complication. I think he's been having a lot of transfusion. It's a severe injury, so he's really inflamed. And I think that the supportive idea now is to reintubate and support this patient on a respiratory basis. So I think that the first things would be as you did, so trying the NO, and if that doesn't go well, you try the paralysis. And I think that the initial steps would be really nice. You don't have, at least from the X-ray standpoint, you don't have any fluid. I think that I would perform a thoracic ultrasound to make sure you don't have any effusions that you could drain and maybe get this situation a little better. And I think that we need to remember that the patient had a PE as well, a small PE, but he didn't have it. And some patients, it's really interesting to see that, because most of the times the patients they do have an anticoagulation pattern of these inflammatory changes from the trauma, but there's a little fraction of such patients that they do enter a procoagulative phase. So I think that we should address this as well and consider that he might have another PE or another situation that could compromise his breathing as well.
Thank you, Dr. Managosa. Dr. Hodgman, would you like to make any comments?
So usually he has no chest injury, so the trigger for the ARDS is an inflammatory response coming from somewhere else, which has to be the abdomen. So probably, I would think at this time that something is going on in the abdomen that is triggered this inflammatory response. That would be my first concern. what it is, I don't know. It's usually some sepsis or some maybe there is a pancreatic leak that is causing inflammation in the retroperitoneum. Something is triggering an inflammatory response. I'm sorry. And the other possibility is this patient was transfused, that he might have Trali. And final, as Dr. Menegoso said, many of these patients are hypercoagulable. There are suggestions now that many of these patients might develop, we always think that this is pulmonary embolism, and there are some papers suggesting that this hypercoagulable state can form clots de novo inside the pulmonary circulation. So they were not embolized, but they formed there because of the hypercoagulable state. Usually happen in most severe traumas where this is a significant inflammatory response, but it can happen in a case like this. Obviously, the inflammatory response is significant for him to develop ARDS. So that would be my order. Something going on with the pancreas, the jejunum, something leaking somewhere, causing inflammation, Trali, and pulmonary embolism. That would be my workup order, and we'll try to rule those out in that order. Thank you.
Thank you, Dr. Hodgman. Dr. Quist, would you like to make any comments?
No, I agree what has been said already. I was cutting in and out of the elevator, but if he's hypoxic, obviously you're going to reintegrate him and then try to optimize his oxygenation. And if you can't, you may have to move on to more aggressive measures such as ECMO therapy.
Thank you, Dr. Quist. Dr. Uncheck, would you like to make any comments?
Yeah. So it sounds like he's in sepsis. We didn't see the white count at the lactate level, but assuming he's in sepsis, so everything that the others mentioned, and I would give him broad antibiotic coverage, 2 or 3 antibiotics, and then to figure out whether it's primary pulmonary or secondary to what's going on in the abdomen, I would try and get a CT scan to. If he's too ill for a CT scan, then you might want to do a preliminary bronchoscopy to see if there's pus, to see if it's primary pulmonary. If that's negative, then take him back to the operating room.
Thank you, Dr. Uncheck. Back to you, Dr. Badami.
Thank you. So coming back to all the comments that the faculty made, his white count was 18, lactate of 2. He was 16, 18, around that range. He was febrile. He was on broad spectrum antibiotics at that point in time. We did do a quick bronchoscopy, and it looked like ARDS, kind of picture primary pulmonary. Abdomen from the JP drains, it was just serous sanguineous output. But that was also a concern in our mind. But at that point in time, even with the paralysis, with the nitric oxide, unfortunately, we're not able to get good oxygenation. His O2 on the gas was still 40, 50 in that range. So luckily, I think we're really fortunate out here being a level 1 trauma center with having a ECMO immediately available for our trauma patients. We consulted our ECMO team that takes care of a trauma patient and initiated ECMO right away. So he was put on VV ECMO via right IJ cannula and right femoral 23 cannula, drainage cannula. At that point in time, subsequently, once he was on ECMO for like 1 or 2 or 3 hours with airway pressure release ventilation, his compliance started getting better, and O2 went from 49 to 104 to 172. 174 actually. His nitric oxide was weaned off. He remained on ECMO for the next week. Slowly, we were troubleshooting from ICU standpoint. His sweep and his oxygenation was improving. His compliance was improving subsequently, and by post-op day 6 or 7, he was on pressure support 10, 10, and 40%. He was awake. He was following commands. This is just an X-ray showing the ECMO cannulation, and you can see the IJ and femoral cannulas. By post-op day 9, he still remained on ECMO, but at this point in time, his vent settings were considered favorable that we ended up performing a tracheostomy. By post-op day 10, he was decannulated from ECMO. Again, the thought process was to keep him on ECMO while we perform the tracheostomy, just in case he has a hypoxic event again. By post-op day 15, his white count started slowly bumping up as well, 23, 25, and 32. By this point in time, he was trached off ECMO, kind of stable enough for him to wheel down to CT, and he got a repeat CT scan, which shows some right and left pleural effusions and a large abdominal fluid collection in the perihepatic space and psoas collection. So this is the CT scan from post-op day 15. You can see some right pleural effusion we placed a pigtail with serous sanguineous output, and this perihepatic pretty decent sized large perihepatic collection that IR was able to actually drain on the subsequent day. So I drained that collection. We sent the amylase level from that collection. It was 683, as we alluded to initially, that there was a high possibility of pancreatic leak, and this is what it looked like. Cultures also grew. Candida remained on broad spectrum antibiotics, antifungal. Since he had a PE, he had gotten initially a lower extremity duplex and subsequently repeated the duplex because he was cannulated for ECMO as well. Showed an external iliac vein DVT. He was initially on anticoagulation, had an episode of like upper GI bleed, so we had held it and then restarted the anticoagulation. From 8 to 28, post-op day 18 to 28, he remained on daily ICU care, slowly meeting the vent, was tolerating tube feeds, continued on antibiotics and therapeutic anticoagulation. A 1 month post operatively, he was again persistently seen to be febrile, had a kind of a white count of 21, 22, hovering in that range. Got a repeat CT scan, which showed the same fluid collection, a little bit less, but pretty much still there. Got IR to evaluate the drain. They actually took the patient back for a drains check and did an upsize of the catheter. From post-op day 31 to 55, he was over the course, was downgraded from ICU. Sedation was weaned off, just a lot of pulmonary hygiene. Tracheostomy was downsized to 6 French cuffless. At that point in time, he also got an upper GI studies to evaluate his swallow function, was able to swallow, tolerate a PO diet. Got a repeat CT scan on post-op day 56, showed decrease in the right-sided perihepatic collection. At this point in time, the repeat amylase that was sent from the drain was 30. CT scan otherwise looked unremarkable. The JP drains that were there were removed except the perihepatic IR place drain. And then on post-op day 63, Drake was decannulated. He was ambulating, tolerating diet, having bowel function, and by 67, he was discharged with a follow-up clinic appointment. I think that's it. Would appreciate any comments.
Thank you, Dr. Badami. Dr. Antrek, would you like to make any comments?
Yeah, great case. This was really one juicy, succulent general surgery. It has everything, really, I'm telling you. And it was exceptionally well managed. You could have gone in there and done a Whipple, and then he probably wouldn't have, with everything else, he probably wouldn't have made it. And then, you exercised cautious restraint, well-judged restraint, terminated the operation when he started to get hypothermic and coagulopathic and everything. It really, and even did Dr. Poot's suggestion, good suggestion with the clips and the tagging the bowel up there. So you have it both ways, but really it's superb. Great case and well handled.
Dr. Antrek, Dr. Hodgman, would you like to make any final comments?
No, I think Dr. Rumtrek summarized this perfectly. This is a great case. The fact that you have access to ECMO in a patient like this is critical because this patient would not have survived if you wouldn't have access to ECMO. And after that, you just wait it out and solve the problem as they were getting there, and you did it. So I have really nothing to add except to congratulate you. Thank you.
Thank you, Dr. Hodgman. Dr. Menagozo, do you have any final comments?
Yeah, just congratulate Dr. Abbas and the rest of the team. I really enjoyed the use of ECMO in this patient. I think that it was a really interesting idea and really saved this life, this patient's life. Congratulations.
Thank you, Dr. Managozo. Dr. Post, would you like to make any comments?
Yeah, congratulations to an amazing case, and Bas, thank you so much for presenting it. I think we all learned a lot from this case. This is exactly the case why you do fellowship and why you do two specialties, trauma and critical care. Because you saved this patient twice, right? You saved him once or twice in the operating room, and you saved him with excellent critical care in the ICU. As Dr. Undrak mentioned, he would have died if you didn't provide good critical care and were able to put him on ECMO therapy. So that's exactly why it's so important as trauma surgeons to understand both good critical care physiology and treatment and operative management. And we're very fortunate in our division. We have Dr. Parker, Brandon Parker. He's one of our faculty here who's doing ECMO therapy within our division. So it's became much easier for us to have access to therapy, to ECMO therapy within our own division. So it's a great help. Thank you for presenting this case, and congratulations. I think it's a case you're going to remember for the rest of your life.
Good, Dr. Post. Dr. Martos, would you like to make any final comments?
Yes, so I have an announcement to do. So this is probably the last meeting that Maya is moderating to us. She's starting her residency program soon. We're very proud that she stayed with us during this year. She was amazing. She grew a lot. Most likely in the next few months, I'm going to start having Maya present her own case for her residency program. So I hope she's gonna be here in a different position now. So I'd like to everybody just to applaud, a round of applause to Maya and for her great job with us. Thank you, Maya.
Thank you so much, Dr. Martos. It was an absolute pleasure being here. I learned so much from these meetings, and I got to meet all of you amazing surgeons. So yes, hopefully in the next meetings, I will be presenting, hopefully.
Yeah. And the next thing, please now send your, we need to schedule the next week's case. Please send your case to Liliana. And let's be sure that you continue having these meetings. We need to schedule in advance. So please book in the next 4 weeks, 8 weeks, 12 weeks. Please send the dates that are available. And the next announcement is that starting July, the second week of the month, this meeting going to be association in partnership with the American Association for Surgical Trauma, WST. So this meeting going to go worldwide. And every second week of the month, you're going to have more people participating. This is a result of 13 years of good meetings of you all participating. So we're going to have even more good cases and more recognition and more worldwide different ways to manage the same patient. So keep the good work, keep talking, keep participating, and keep presenting your case, please. Okay. Thank you, everybody. And remember, the ones that didn't book yet, in end of July, you're going to have the Pan American Trauma Society meeting in Florianópolis, Brazil, with SBITE, with CBC. And also in August, we're going to have the World Trauma Congress in Japan. So a lot of good conference, a lot of good opportunities to meet each other in person. I know the PUS is going to be in Florianópolis. You're going to show all the Florianópolis beaches and place to go. And again, that's what's amazing about this meeting. We meet each other during the whole year here, and then have opportunity in person at Pan American and SBITE meeting. Thank you all. Maya, you finish the meeting, please.
Thank you, Dr. Martos. So I have an announcement. I know that for everybody who attended the meeting last week, I didn't have the code, but I've sent the participant list to the CME office, and they said they would enter all of your credits. They would do it manually. I don't have the code for today either because it was a very last minute presentation. So after the meeting, I will get the code, and either they will enter the credits for you all, or I will email you all with the code. So thank you all for attending, and hopefully I will see you soon.
Thank you.
Yes.
Congratulations.
Congratulations, Dr. Maya. You've come a
Thank you,
long
Dr.
way.
Manjari.
Yeah.
Congratulations. Bye-bye.
Thank you, Dr. Post. Bye-bye.
Yeah, no,